Hi, I'm Jonathan Silverberg, and I'm going to be talking about topical JAK inhibitors. These are my disclosures. Some of these will be relevant to what we are discussing today in terms of some of the novel topical agents in development. We'll start off really by just thinking about some of the currently approved topical therapies for atopic dermatitis. We know that we have corticosteroids, calcineurin inhibitors, particularly tacrolimus and timicrolimus, and then, of course, newly, the phosphodiesterase C4 inhibitor, crisaborole. But there are still a number of unmet needs in topical therapy for atopic dermatitis. We certainly would like therapies that don't have the steroid adverse events. We want therapies that are potentially as or more effective than topical corticosteroids, options that have that same sort of rapid onset of effect, perhaps even faster onset of effect than corticosteroids, and of course with good safety and tolerability. So we have a number of agents in development right now within the topical realm for atopic dermatitis, and many of these may actually fit some of those key unmet needs in the disease. So we'll talk first about the topical JAK inhibitors, namely topical ruxolitinib and delgocitinib, the topical aryl hydrocarbon receptor modulators, which is particularly topical tapinarof, and then some other agents briefly. So let's dive in and look at topical ruxolitinib. So these are data from topical ruxolitinib phase 2 study. So topical ruxolitinib is considered to be a selective JAK1, JAK2 inhibitor. We know that with dosing getting very high, a lot of these drugs lose some of their selectivity, but at least based on the sweet spot in terms of dosing, this would be a selective JAK1, JAK2 inhibitor. Their phase 2 study included patients ages 18 to 70 years with active atopic dermatitis, so this is adults only, with chronic, mild to moderate disease. And a particular nuance to this study was a limitation of body surface area from 3 to 20% body surface area. And there are a variety of different dosing strategies that were tested. So 4 different doses for ruxolitinib, with the highest being ruxolitinib 1.5% twice a day. And very nicely here, in addition to a vehicle control, there was also a control, an active comparator control, with triamcinolone 0.1% cream as well twice a day. And then the period here of treatment was for 8 weeks, and that is where the primary efficacy endpoint was assessed. And so what you can appreciate here, and I'll focus in on really the lighter blue vertical bars for these graphs, because that is the week 8 primary efficacy endpoint, is that when you look at the different doses, which is noted on the bottom here, 1.5% BID, which is that highest dose, gives you the highest efficacy with respect to the IgA clear, almost clear with a 2-grade response, and for the EASI-75 responses as well. The 1.5% daily dose also looks pretty good, but the twice daily does look to be more effective than the once daily dose. But what's fascinating is when you look at the triamcinolone 0.1% active comparator group, you see reasonably good results, but you can appreciate that the 2 higher doses of ruxolitinib appear to be numerically superior to triamcinolone 0.1% cream. And so this is something that's very exciting to have a non-steroidal option that appears to have as much kick as one of our mainstays of therapy within the topical steroid realm for this disease. Now, that was their phase 2 study, and that's sort of the older data. Now we have 2 phase 3 studies that recently presented the results. These are randomized, double-blind, vehicle-controlled studies, the TRuE-AD1, TRuE-AD2 studies. These studies look at adolescents and adults, similar severity criteria from the phase 2 study, but really focusing in on 2 doses, the ruxolitinib 1.5% BID and the 0.75% BID doses, 8 weeks as well, monitoring and long-term extension. And here it's a little bit of a busy figure, but what you can appreciate is that at week 8, which is that primary efficacy endpoint, the ruxolitinib 1.5% BID, which is the darker colors, really achieves the highest efficacy for the primary endpoint of IgA clear, almost clear, as well as for the EASI-75 responses. Now, what about topical delgocitinib? This is a little bit further behind in certain respects, but we have now phase 3 RCTs from Japan, looking at adults with moderate to severe atopic dermatitis, and looking at delgocitinib 0.5% ointment. And what you can appreciate is that fairly early on, already by week 1, there is a significant separation in a modified EASI score for this study that continues out to week 4. At week 4, you can appreciate there are significant improvements of this 50% and 75% improvements of the modified EASI score, as well as significant improvements in terms of IGA success with the ointment. Now, the ointment is officially approved for the treatment of adults with atopic dermatitis in Japan, and the cream is currently under investigation for atopic dermatitis in North America and Australia. And so we look forward to seeing more readouts from the studies of the cream soon. Now, topical tapinarof is a topical aryl hydrocarbon receptor modulator. This is really a novel mechanism in many respects for us. It is something that conceptually, mechanistically, we may be familiar with in terms of coal tar's effects, but really this is a much more nuanced mechanism and really different than coal tar and much more precise. So we have results now from a phase 2b RCT looking at adolescents and adults with moderate to severe atopic dermatitis. So whereas ruxolitinib was mild to moderate, this is moderate to severe. And with the BSA restrictions of about 5 to 35%. Multiple doses tested for tapinarof, with the highest being the 1% BID, and the primary efficacy endpoint was assessed at week 12, which is 4 weeks later than the time for the ruxolitinib studies. And so what you can appreciate is that really over time, the 1% daily dose achieves really, seems to have sort of the highest effect by weeks 4 and week 8, and then when you get to week 12, that 1% BID really hits the peak efficacy for the IGA success as well as for EASI-75s, but that 1% daily is really not that far behind. Seems to have a little bit of a slower onset of efficacy, but give it enough time and really has robust effects. And overall good safety. Most common adverse events were nasopharyngitis, folliculitis, and atopic dermatitis. Now, there are many other topical therapies in development for atopic dermatitis, and this table just summarizes just a few of them. We can appreciate that there are multiple other JAK inhibitors with different specificities that are under investigation, combinations of JAK1 and TYK2. There are novel lipids that are being investigated for even mild atopic dermatitis. We're also seeing now multiple topical phosphodiesterase E4 inhibitors being investigated as well, which may broaden that class for us, as well as some TRPV1 topicals. So to summarize, these nonsteroidal agents may offer efficacy that is comparable to or even better than mid-potency topical corticosteroids without those nasty steroid side effects. The JAK inhibitors in particular have shown a rapid onset of efficacy, and some of these agents, importantly, may have multiple indications where these may not be only effective in atopic dermatitis, but these may work in a variety of other disorders. Ruxolitinib is right now under investigation for vitiligo. Delgocitinib may be under investigation for hand eczema as well. And then tapinarof is also under investigation for psoriasis. So we look forward to having a growing toolbox of nonsteroidal topical agents to offer our atopic dermatitis patients. Thank you very much for your attention.